A very good morning to all of you, and we welcome you again for another webinar in our CPD webinar series. Today's program will be on key aspects of immunization. This is a CPD program for GMOA members co-organized by the Government Medical Officers Association and the Society for Health Research and Innovation. Our distinguished lecturer today is Dr. Tharanga Navodani. She is a consultant community physician attached to the RDHS office at Kalutara. Let me go over the usual housekeeping rules. This webinar link will be available from 9 a.m. to 9:50 a.m. to join in, and no late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points, and the CPD points are strictly adhered to the NCCPD guidelines. This is done to improve and maintain the standards of our CPD programs conducted at SRI. We thank you for always adhering to these strict rules in maintaining our standards in our CPD programs. We would also like to say to switch off the video and mute your microphone to avoid any disturbances. As usual, there will be a Q&A session at the end of this webinar, so please feel free to type in any of your queries during the lecture in our chat box. Since we know that there is a problem with power cuts these days, we will post a phone number in our chat box for you to send us a message if by any chance you get logged out of our lectures due to the power cut. We hope you enjoy today's very important lecture on immunization, and I would like to welcome Dr. Tharanga to go ahead with the lecture. Over to you, madam.
Thank you very much. And I think this is a very important current topic, and I hope you will all benefit from this lecture. I think these days it's very important to know about our immunization program and the basic concepts of the immunization program. It's a vast subject. Anyway, I'll try to cover the core or the basic concepts of immunization. Then I think all of you are, as doctors, you can understand or work out the problems or issues related to individual vaccines. So let me share my slides. Okay. Can you all see my slides? Excuse me.
Yes,
can you see?
Madam,
Yes,
we can see your sides.
Okay. Yes, this lecture session, I was asked to limit to 1 hour. So I prepared slides to try my best to limit for 1 hour. So this overview of this presentation is I will first introduce about the vaccination, then history of immunization and our national expanded program for immunization, and the other vaccines available in Sri Lanka, and about timing of vaccines, and the most important things, cold chain and injection safety. So, yeah. As introduction, first of all, I must say vaccination is the most important and effective, safe intervention in the health system. Even explains in the history, it's more important even than antibiotics, and only second to the safe drinking water. So it's so important for reducing morbidity and mortality if these vaccines are of good quality and stored properly and handled properly, and it should be given safely to get all these benefits from vaccination. So what vaccination do means, how do they work? They mimic like natural infection, but don't give rise to those complications and all these symptoms. Maybe having minor symptoms, with that they mimic natural infection and give rise to and stimulate our immune system to develop immunity as if we got the natural infection. So all these things are very basic. This slide is not okay. Then when the vaccine producers are developing vaccines, they try to achieve all these features which should be there in an optimum type of a vaccine. Those are, they should be effective in preventing the disease, so at least it should reduce the severity of the infection of disease. Like that, our COVID vaccines, most of the COVID vaccines, they don't totally prevent getting the disease, but they reduce the severity, complication, and death due to such diseases. And the optimal vaccine should provide durable and long-term protection against the disease and should achieve immunity with a minimal number of doses. Ideally, it should be one dose, but with the properties of the vaccine, we have to give further doses, additional doses, or booster doses, and provide the maximum number of antigens that confer the broadest protection. That the vaccine dose, it determines by the amount of antigens which it should be in a given volume, and it should not cause any adverse events or should give mild adverse events, are stable to storage for long time at a given conditions, because we cannot give vaccines within a short time period. Is produced in somewhere else and has to import and have to transport to another place, and we have to distribute them, so it should have prolonged period to store in a given and instructed conditions, and now available in a general for mass production should be there, because this is a mass programs. Vaccination is not an individual orienting, it's a population or community based program, so it should be affordable to a country or a community. So why immunization is that much important? It says globally each year vaccination prevents more than 2.5 million child deaths globally, and evidence says even more than that. In additional 2 million child deaths could be prevented if the vaccination coverage is optimal. As you all know, our country in Sri Lanka, we have achieved almost, I can say 99% to 100% coverage with our expanded immunization program, but compared to our country, even Southeast Asian region, they still don't have that optimal coverage. And when we consider other countries like that, underprivileged countries, especially in African countries, like they don't have that good coverage of vaccination. So if we can improve this vaccination coverage, we can save millions of lives. So these are the importance that vaccines promote health. That means they help healthy people to stay in healthy. So it's the important we target healthy people. So these vaccination programs should be standard and optimal, as we are addressing healthy people and we want to get them vaccinated. Those are apparently healthy. The other thing, vaccines have expansive reach that protects individual, not only that individuals themselves, but on all the communities and the whole population. Even past vaccination protects us without vaccination. For example, when we consider smallpox vaccination, we are not getting smallpox vaccine, but still we are protected. We don't get smallpox disease because it's already eradicated from the world due to the vaccination. Now that disease is no more there. All these things are due to vaccination programs. So we are protected even without vaccination. So vaccines have rapid impact. Effects are immediate. You can see we experienced a huge outbreak during past few months with corona. With improvement of the coverage, first and second doses, we have above 80% coverage. So we could able to mitigate our big pandemic, even though there are patients now we don't see much complications compared to previous outbreak. So it gives rapid impact and effects are immediate. Sometimes it takes only 14 days to get the optimum immunity. So it's very important and they save lives and expenses. When we think about managing a tetanus patient or something like serious patient, it costs uh, millions of money, but we can vaccinate millions of people with the same amount of money. So this is very important. So this picture shows how the immune people protect others. In the picture, the left side, we can imagine the situation when the corona virus is there, all of us are non-immune. So if there is a one patient, almost all contacts get the disease and whole immunity get uh, whole community will spread the disease. So in other side, the right hand side picture shows once the majority is vaccinated. So it is like 75% is vaccinated. When the infected person contacts these vaccinated or immune people, protect the even the non-immune people from spreading. But when there is a non-immune person, he can spread to some non-immune people, so the outbreak gets mitigated. So this picture shows why does my choice matters to others. I think this is self-explanatory. These blue symbols denotes non-immune but still healthy. All these blue colored in the first row are healthy non-immune people, like in the first corona outbreak. When no one is immunized, so all the community will get the disease. Only the few exceptions. And second row, when we have only few on and off vaccinated immune people, but majority are not vaccinated. So what happens is the same, like even in non-immune community, the disease gets spread rapidly. So in the last row, you can see these yellow symbols that majority are vaccinated. Only a very few are non-immune people. So the spread of the disease is prevented or barriered. So these immune people behave as a barrier for the non-immune people also. So this is very important. As you all know, COVID vaccine cannot be or still not recommended under 12 years in our country. So still we recommend vaccination with corona with the about 12 children and adults. So if you want to have 75% of immune people, that's epidemiologically it says, we need at least 75% vaccinated or immune people to barrier or prevent or to develop herd immunity to stop the spread of disease. So if we want to protect our children from the COVID infection, we as adults, we all have to get the vaccination. So it shows from this picture, it's very important, all of us, and we all have to support and promote community get the vaccination with to achieve this type of herd immunity. So this picture also shows how herd immunity, how only some get vaccinated, what happens, it's not just only the protection for those few individuals, but there's no protection for the whole community. So that outbreak can spread. So this is about the history of vaccination. Vaccination was first introduced by the Edward Jenner in 1798 against the smallpox vaccine. And in Sri Lanka, we have introduced, they had introduced smallpox vaccination to Sri Lanka in 1886. Our immunization program has such a long history, and during that period, it was compulsory through a vaccine ordinance. So every person must get this vaccine. So by those laws and programs, we could achieve the targets. And now its smallpox is eradicated. Eradicated means disease, both disease and the virus is no more there. So we don't have to be fear about that disease. It's eradicated. After that, gradually with the introduction of other vaccines, Sri Lanka also introduced most of these vaccines through our vaccine program. But in 1978, this expanded programs was launched, and it's a milestone or key turning point in our vaccination program. It's very now, according to the expanded EPI program, we have to reach each and every child or woman who are eligible for this vaccination. So, according to our EPI schedule, we take only the WHO pre-qualified vaccines. All our vaccines in the EPI program are WHO pre-qualified. That's a long process. They study, they give them with evidence, they provide the standard vaccines. So, Sri Lanka purchase only these good quality and WHO qualified vaccines. All vaccines are safe and effective. No doubt about that. And as any other thing, this is not entirely without risk. As these are biological preparations, anytime with anything, you can be at risk of getting adverse events. So anyway, benefits far outweigh of the risk. It's getting vaccination is 1,000 times safer than getting the disease. So this is a success. Not only this, there are several success stories in our immunization program. This is the very good success story. This is with the polio coverage. You can see this blue bars shows the number of polio cases occurred in Sri Lanka. With the coverage, improving the coverage of oral polio vaccine, you can see now there are no polio cases. I think most of the doctors in this forum also haven't seen a single case of poliomyelitis patient because there was no polio case detected case of polio we have in 1993. But sometimes you might think whether we missed these polio cases. No, it's not. We have very good surveillance system. Any child with polio, when any child with paralysis are investigated for polio. So we won't miss, and we don't have polio cases after 1993. And then this is about this protection. You can see with the increase in coverage, we see only the few cases, so no cases. So this is about whooping cough. You can see with the increase in coverage, we don't see much patients, so at least minimal, very rarely. Even though all these are, this is with the tetanus coverage, how our patient load reduced. So I think this is a very important graph. You should understand this. With the success story of vaccination, we get a picture like this. It's due to the evolution of vaccination program. We can understand this with our COVID vaccine. I think if you all can understand, this red line shows the disease pattern. And the green dotted line shows the vaccination coverage. In the pre-vaccine period, like we all were in the onset of COVID outbreak, we all were waiting for a vaccine, and scientists eagerly or tirelessly tried for vaccine. And those days we had we saw many complications and the patient load and the deaths. So at that period, community is willing and eagerly coming for vaccination. You can see with the increase of coverage in green dotted line, with the increase of coverage, disease get reduced. I am explaining this with regard to COVID as it's easy to understand. This happens to each and every vaccine with the maturity of the vaccine. So once the vaccination coverage is increased, you can see the reduction of the disease. And then with the optimal level of coverage, you won't see the disease, and you won't see the complications, and you won't see the deaths or the minimal numbers. So with that, people think, why do we get the disease? It's a mild disease. We don't want to get the disease. No more patients, as you might think, why we are getting polio vaccine if it's not there for more about 20 years. Like that, people also think, why do we get the vaccine? And at the same time, at the bottom, you can see light blue line. It shows the adverse events occurred with the immunization. As I told, each vaccine can give rise to adverse events, but it's very less and very minimal, or maybe 1 in millions of doses. So people don't see the disease. People don't see the complication, but they see only the adverse events. What happens then? They think no need to get the vaccine, and vaccine coverage goes down, like for our third dose. Then the vaccine coverage goes down, non-immune people numbers will be increased, and again outbreaks can occur. With the outbreaks, again people will resume and come into vaccination, and again we can have the optimal coverage. But the problem is, before this, even though it's a small graph, this takes years, maybe decades. So we can experience more outbreaks and more problems with relate to diseases. This happens to routine other vaccines too in developed countries, in some communities in our country also. Some people, it's rare in our country, but some people don't get some vaccines. So with that, even though we don't experience diseases, still those pathogens, so the virus or the bacteria is present. So with these international travels and movements of the community, we can again develop that outbreaks. Even polio, we can get outbreaks if we don't vaccinate, because it's there in the Southeast Asian region also. In some countries for last few years, even though now it's in the pipeline of eradication, that polio might be eradicated within several years or decades, but still we have to vaccinate, and we have to achieve optimal coverage to eradicate or get rid of these diseases. So it's very important. All of you should understand this graph. This is the evolution of vaccination program when it's matured. So to understand about the different vaccines, I think I don't have time to discuss about individual vaccines, but if you know these types or groups of vaccine, you can work out about the other things. So we have different types of vaccines. Some are live attenuated vaccines. That means that pathogen is there. It's a weakened pathogen is there. So very rarely, 1 in millions of doses, they can give rise to the disease. So that's very rare. It's mainly occurred in immunocompromised patients. So we don't vaccinate immunocompromised people like HIV/AIDS uh, patient with long-term steroids, or even in pregnancy, we don't give live attenuated vaccine. So these are these TB, BCG, oral polio vaccines, MMR, this yellow fever, all these vaccines are live attenuated. So you can work out about the individual vaccine. Then others are inactivated, maybe in the whole cell killed vaccine, like in our Sinopharm vaccine, they are it's a killed vaccine, or maybe subunits, or in other particles like that, mRNA vaccines, like that. And the another type is toxoid, tetanus and diphtheria. So these vaccines, other than the live vaccines, never give rise to the disease, because there's no the pathogen is not there, only they are stimulating our immune response, mimicking the natural disease. So other than these antigens or viral particles, or that main component, there are excipients in the vaccine. This is also important when we give vaccinate community. Some people may allergic to these components. So these are mentioned in the manufacturers' leaflets and our guides in EPI vaccines. These things are used as excipients in our vaccine. So if the people or the child is allergic to these excipients also, we cannot use these vaccines to such individuals. So this is our national EPI schedule. According to that, we have to vaccinate each and every child according to this schedule. In the first year of life, every child is getting BCG vaccination. 4 hours is optimal, but if a child is very low, severely premature, once they are fit for the discharge, they can get the BCG vaccination. So it's at birth vaccination, and after that, we vaccinate children at 2nd, 4th, and 6th months with our pentavalent vaccine, which contain DPT, hepatitis B, HIV, and in addition that oral polio vaccine and fractional Hpv first dose. And at the 4th month, again, it's repeated, and 6 months oral polio and pentavalent is given. And at the 9 months, we vaccinate children with MMR. It contains mumps, measles, and rubella vaccine first dose. And in the 2nd year of life, at 12 months, at the completion of 1st year, we'll vaccinate children with live JE. And at the 18 months, we'll again repeat with oral polio and DPT 4th dose. And at the completion of 3 years, they are vaccinated with MMR 2nd dose. So this is the national EPI schedule for school going age. There are 2 vaccines available in school vaccination program. And even at 5 years, this is not given at school. Most of the time they are vaccinated at MCH clinics with oral polio and DT, only DT as 5th dose. So if some one has not taken this vaccine during the school medical inspection, they are given this vaccine also. And mainly our school vaccination program target grade 6 and grade 7. At the grade 6, they are provided with HPV first dose. And after the 6 months of first dose, they should be given 2nd dose of the HPV vaccination. This is relatively recently introduced vaccine, and this is very important as it is preventing cervical cancers. So this is a vaccine against the cancer. So it's very important. When we decide about the age or timing of the vaccination, we use that experts use different research evidence for the optimal time for this vaccination. So with regard to HPV vaccine, this should be administered before the first sexual intercourse. And we won't get the highest number of coverage for considering school leavers and optimal time and these sexual relationships. Everything is matter to decide on this time of vaccination. So all our school children in grade 6 are eligible for HPV vaccine. So they need 2 doses for the optimal immunity, and as doctors you all should encourage children to get this vaccine. As I told, always benefits of this vaccine outweighs the complications of the disease. And at grade 7, at the completion of 11 years, they are provided with adult tetanus and diphtheria dose. It's also very important. You can identify with the next slides. As we mentioned, according to our EPI schedule, already they have taken 5 tetanus toxoid doses. So they are protected up to this age for the tetanus. When we give another booster dose at 11 years, they develop further, or they boost up their immunity for another 10 years, and no need of giving tetanus doses up to 10 years. Those are the 2 main vaccines given in school health program. And as doctors, even working in the hospital and even as in a community, in your GP practice, you should promote to get children to get these vaccines, because they are very important and they don't have that our optimal coverage like childhood vaccines. As I told, they are 99, no 100%, but still the school vaccination coverage is not up to that level. There are many reasons, but still they are very important. And another one, this is not that important. We are giving vaccinate females of childbearing age with rubella containing vaccine. Nowadays, we don't have only rubella vaccine. We have MMR vaccine. We give MMR vaccine to 15 to 44 years old childbearing female if they are not vaccinated with previous rubella containing vaccines. But now there are very minimal number of females without rubella vaccination. So if there is some, you have to vaccinate them with MMR vaccine for rubella protection. And this is about vaccination, national immunization program for pregnant mothers. As this slide is very crowded, I'll explain it with this slide. According to the new schedule, if the woman is protected with 6 doses, that means they have received 5 doses during childhood and next dose during the school going age. Now they are protected with 6 doses of tetanus toxoid. As I told, they have protection for 10 years. If the pregnancy is within 10 years of the last dose, they don't want to get the tetanus toxoid. So up to 10 years, no need for tetanus toxoid. But if the pregnancy is 10 years later than the last dose, we can offer 1 booster dose. So this is one schedule. This is for the women who have protected with tetanus containing vaccine and those who have proven documents. If they have written documents only, we follow this schedule. If they don't have this written documents, or we cannot prove their vaccination status, then we have to follow the older schedule. It's during the first pregnancy, we give 2 doses after 12 weeks of pregnancy, first dose, and next one is after 6 to 8 weeks of the first dose. And in the subsequent pregnancies, we offer only one tetanus toxoid for subsequent 3 pregnancies. And after 5 tetanus toxoid doses, we consider them as fully immune, that they are protected for rubella, no need of more vaccines, more toxoids. So as your request and from the organizers, I just mentioned this is not EPI one regarding the post-exposure tetanus toxoid. Earlier, I explained about the pre-exposure tetanus toxoid. This is about the schedule for post-exposure tetanus vaccination. That means if someone comes with a wound or some with the risk of getting tetanus. So these people also, if they have received all tetanus containing vaccine doses according to the EPI schedule, that means 5 childhood tetanus doses and 1 during the school going age according to the EPI schedule, and they should have the written evidence for that vaccination. No need for vaccination. Even in between, such as if a child in grade 3 comes with a wound, you don't want to give them tetanus toxoid because they are already protected. So even after completion, within 10 years, no need to again give tetanus toxoids because they are protected for another 10 years after the ATD vaccine. So, but still, if you think as a clinician, someone decide, no, this is a very severely contaminated wound, like there may be deep multiple bites, dog bites like thing, you can give another 1 dose to boost up the immunity. If the time period is, it's after 10 years of the last dose, we have to boost up with 1 dose of tetanus toxoid containing vaccine, maybe tetanus toxoid or ATD, according to the availability. For those who have not received tetanus containing vaccines according to the EPI schedules or defaulters, or no, if there's no written evidence, we have to follow the older schedule, like we have to vaccinate first dose at the earliest on the first day, and second dose after 4 weeks, and third dose after 6 months of the second dose. And after that, after 5 years of the third dose and after 10 years of fourth dose, we can offer booster doses, fourth and fifth doses. After that, they are considered as protected for tetanus, and it causes long-lasting immunity. This picture shows about how tetanus toxoid give rise to immune response in our body with the doses. With first dose, it's minimal immunity. With the second dose, it's increased, and with third dose, it's somewhat improved, and with fourth and fifth doses, the immunity is boosted up and remain in a optimal level at the immune, they are immune for the disease. So when we consider our practices, we see sometimes people get too much of tetanus toxoid once they go for GPs. At every time they give tetanus toxoid. This is unnecessary. Evidence says only 5 adult doses give rise to lifelong immunity. So these are generally the contraindication for all vaccines. I think we don't have time for going individual vaccine contraindications, indications, and everything. You can refer that from the immunization handbook, which is online available in the Epidunit website. Generally, these are the contraindications for vaccination. If someone is ill with the acute illness at the time of vaccination, you cannot give vaccines. And if someone has progressive neurological illness or allergy to the vaccine, or any of the component of the vaccines, all these are contraindications for vaccinations. And live vaccines are contraindicated in immunocompromised status, like long-term steroids, HIV/AIDS, pregnancy. So these are the absolute contraindications. Others, there may be according to the vaccine, but generally these are the contraindications for all vaccines. Oh, sorry. This is the next slide. These are not contraindications, means these are false contraindications. Sometimes even health staff also think these are contraindications and delayed getting vaccinations. If a child had mild illness without fever, like mild cough and cold, you can vaccinate. And family history of adverse events, like elder child got the adverse event, even still the younger child can be vaccinated. So these are not contraindications. Treatment with antibiotics or short-term steroids. Asthma, atopy, not the acute asthmatic attack, but generally asthma, atopy, eczema, those people can be vaccinated at the age appropriately. And prematurity is not a contraindication. And contact with the person with infectious disease. And stable neurological illness like cerebral palsy, Down syndrome, they all can get vaccines. And defaulted vaccination, that means one may have second and fourth month vaccination. After that, they come for the vaccination after 1 year. They also can be vaccinated again. So past history of same illness. As you know, if we get the COVID illness, we get the vaccine. Likewise, other vaccines also like that. Even in low weight, in otherwise healthy child can get vaccinations. These are not contraindications. So as doctors, you should encourage parents to get age appropriate vaccination. It is very important and should not unnecessarily delay. Sometimes those who are not in the public health may don't know about this age appropriateness. We consider within 2 weeks we have to give the vaccination if it is called as a age appropriate in the first year of life. After that, we consider about 1 month to consider as age appropriate. So as doctors, you all should encourage people to get the age appropriate vaccination. Should not unnecessarily delay the vaccination. So this is about if a child has missed vaccination, like previous example I mentioned, no need to repeat the doses or vaccines already given. As I mentioned, they had taken only the second month and fourth month first and second doses, but not come for the third dose at 6 months. So if they come at after 12 months, even you can start vaccination with the third dose. No need to repeat the given vaccines, because this our immune system does not forget the past memory. So we have to continue as if there's no delay, and intervals between doses should be maintained. And usually we take 8 weeks, but we can reduce it to 4 weeks, like if it's for pental like thing. Accordingly, we have to give age appropriate vaccines. And if a child does not have a written evidence, maybe this the PHM also maintain cards. If a child does not have any valid evidence, so you can continue or start vaccination as if they have never immunized previously. And if they have delayed or missed vaccine, can they be vaccinated with a number of vaccines? Yes. Having several vaccines at once is safe. It's proven scientifically. If you have to offer MMR also, you can provide age appropriately. But if you are giving live vaccines in a different time. If you are giving one live vaccine today, you have to delay the second live vaccine up to 4 weeks. You can only give live vaccine 4 weeks apart. This is not relevant to other killed vaccines and other inactivated vaccines. So, I missed one slide, I think. I didn't talk about this, our vaccines available in the private sector. These are the vaccines, that slide moved upward. These vaccines are available in the private sector. These are the vaccines: rotaviral vaccine, pneumococcal, varicella, human papilloma virus vaccines, and influenza vaccine. Why these are not available in EPI vaccine? Among EPI vaccines, you should understand, as a country, there are numerous factors relevant to deciding to include in the EPI schedule. As I mentioned, if we include in a EPI schedule, we have to consider about sustainability. Each year, we have to continue with that vaccine. We could be affordable, and always we measure burden of the disease with the expenses of the vaccine. So there are many factors: disease burden, vaccine availability, and feasibility of providing vaccines. Everything matters to introduce vaccines to EPI schedule. Sometimes we have to limit vaccines according to the budget available. So all the vaccines we can have sustainable provision, we introduce to EPI vaccines. That doesn't mean these vaccines are not good or anything. It's due to several other factors. So these are available in the private sector. If anyone wish, they can get these vaccines through the private sector. So when we talk about vaccinations, these things are very important in relation to vaccines, because these vaccines are biological preparations. So they are potent or viable in given conditions only. So it's very important to maintain cold chain. And the other thing is injection safety. Both these aspects are more important than the vaccine itself. So cold chain means it is the name given to system of people and equipment that ensure the correct quantity of potent vaccine reach the client. I think this you should understand. This cold chain is people and equipment. They are maintaining the chain of storage, optimal storage conditions to the vaccines. Otherwise, these biological preparations will get destroyed, or the client will not get the optimal benefit. So if it is not stored properly, these vaccines will be just injecting water like that. So there's a very good system in our national EPI program. This is like this also you should know, every doctor should know about this cold chain. From the manufacturer, we in the Ministry of Health, as you all know, epidemiology unit in the Ministry of Health is responsible at the national level for deciding on and policy making and implementing guidelines, everything. Epidemiology unit is the responsible agent at national level. So with the expert committees, technical committees, they decide and prepare all these things and decide on the manufacturers. And from the manufacturer, they get every documents, evidence, and through the WHO also all these things are checked for the safety and effectiveness. After deciding on purchasing, they order these vaccines, and the experts from the EPID unit, higher authorities, go to the airport and take over all these lot or vaccine amounts after checking cold chain maintenance during the transport. There are monitors and the things which send with the vaccines. So at the airport, EPID unit take over all these vaccines after checking about cold chain maintenance. After that, they store at the EPID unit. We have central stores for vaccines. In the cold rooms, they store all these vaccines with the optimal temperature, suitable optimal temperature levels, and these are very strictly monitored, and they have sophisticated systems of cold chain monitoring. Even if there is minor changes in this temperature, experts or designated officers will get the SMS that the temperature change about the temperature changes. So it's very strictly monitored, and it's guaranteed our cold chain monitoring. So from the EPID unit stores, they usually they monthly release vaccine stocks to regional MSDs at district level. And there are also these district level store facilities are always supervised, monitors by the EPID unit, as well as from the district experts and district teams. Always there are cold chain monitors, and they have adequate facilities for freezing and refrigerators. From the RMSD also, regional medical stores, they monthly send vaccine slots to divisional stores in the MOHs and the hospitals. So at the MOH office, usually they have about 2 months stock of vaccines. They also have to maintain vaccine vial monitors, daily temperature reports. Not only the MOHs, there are large hospitals, they store vaccines. They should daily monitor the temperature. Even there are some gadgets for monitoring these cold chain, as doctors working in those sites, so in charge of vaccine. You also have to check whether these designated officers are knowledgeable or maintaining these temperatures. Like that, our cold chain monitoring system is at the optimal level. They daily chart the temperature, and vaccine vial monitors are there, and some gadgets to take through the computers. Computerized systems are also there. From the MOH, they send to the vaccination center vaccines to the vaccination center. Even with these vaccine vial monitors, you may have seen these things. We monitor about the temperature change according to the vaccine vial monitors. So if the vaccine vial monitors have been changed, we have to discard. So if this last two, you can see the vaccine vial monitor changes occurred, we have to discard whole lot of these vaccines. So likewise, in our system, it's guaranteed our cold chain monitoring is at the optimal level. So even though we always think about the high temperatures, but some vaccines are destroyed by the freezing also, like hepatitis B, DPT, DT, like those vaccines can be destroyed by freezing. I think you may have experience in tetanus toxoid. Sometimes you bring in a bag full of ice cubes. So already that vaccine has been destroyed. So those vaccines cannot be freezed. But some vaccines, or even though the optimal temperature is 2 to 8, even they are not destroyed by freezing, like BCG, MMR, measles. These vaccines are not destroyed by freezing, but destroyed by higher temperature. So always when we consider about these biological preparations, it's very important to maintain the optimal temperature. So these are the instruction given to store in a fridge. If you want, you can refer this later. These are the gadgets in MOHs. This is a fridge tag. It shows the temperature, and another thing is a freeze tag. All these are there. And then it's about keeping the potency of vaccine. Then the most important thing is injection safety. When we consider about injection safety, that should be safe to the client, safe to the healthcare worker, as well as safety should be maintained to the community. So when we consider injection safety, always you have to do the proper recording, check whether the correct client is there, check the page about immunization, about the side effects or previous AEFIs, allergies, everything you have to check before giving a vaccine. In addition to that, you have to screen for the contraindications mentioned above. So then with this, after we are designing on the vaccine given, you have to check about the cold, that vaccine vial monitors, expiry date and everything, and about turbulence in the vaccines and everything you have to check. And then about the correct route of administration, it's very important. You have to decide on it's all instructions are given in the immunization handbook, and with the immunization program all instructions are given. We have to decide on the correct route of administration and correct technique. In MOHs, all the staff involved with these vaccination programs, they are trained for these vaccination techniques, even PHMs and PHIs. So there are many safety measures, like in our EPI program, we use AD syringes. So these are single use. And when we use multi-dose vials, always you have to consider about contamination. And after the giving vaccines, you have to keep the client for 20 minutes to observe for side effects or adverse events following immunization, special acute things like anaphylaxis, allergies, like things. So this is the way of disposing syringes. You should not recap, and you have to always use these safety bins for the disposal of these syringes. And as with this mass immunization, and even with our MCH clinics, they are in the villages, so far away from medical institutions. So every place, in everywhere, if you are vaccinating, you should have a emergency box. There are guidelines to have a emergency box. Even if you are vaccinating in a hospital premises, even with the ETU facilities, there should be an emergency box with essential things like adrenaline and adrenaline administering syringes. Everything should be available in the close proximity at the injection site till we taken the patient to ETU. That's very important. As I told you, it's they are healthy people, healthy children, so no one will expect anything, any adverse events, even mild adverse events with the immunization. So it's very important to consider about adverse events following immunization. This is not only the side effects related to vaccination. If people think it is due to vaccination, it's also we consider as an adverse event, and we have to investigate about that. So in the mass immunization also, we have problems. This is about the importance of detecting AEFI, or even though all these vaccines are safe and effective, our success or sustainability of our vaccination program depend on the public trust. If they don't come, like we experience for the third dose, we have to struggle for vaccination. So always we have to keep our trust about our vaccination, but still our community rely on our staff and they come for the other EPI vaccines. Only we have problem with this third dose. So anyway, public trust is the key to success. But as I mentioned, always these vaccines are with may have adverse events, maybe mild adverse reactions, or even there may be some serious events very rarely. So these are 4 anxiety-related adverse events: fainting, hyperventilation, vomiting, and very rarely convulsions. These are most of the time we experience with adult vaccination or school vaccination. So these are minor reactions, local maybe pain, swelling, redness at injection site, and fever, irritability, malaise. If you have these systematic reactions like fever, malaise, that you are sure about you got the potent vaccine. If you don't have any of these side, this may be that vaccine may not be potent. I answered the question. Sometimes you ask about our government vaccines give rise to these symptoms and at minor side adverse events, but sometimes private sector vaccination doesn't. But we don't know. We monitor our we have guaranteed very good quality vaccines. We maintain optimal cold chain maintenance, optimal injection safety. With that, we are giving potent vaccine. So you can have that minor reactions with these vaccines. But in compared to private sector, that is, we don't monitor the cold chain or other thing, but we train them. We means EPID unit train them, but we don't monitor the cold chain maintenance of the private sector vaccines. So this is about mass immunization, which commonly these issues can occur with mass immunization. That when we are providing vaccines in large scale in mass immunization, we increase the vaccination centers, we increase the numbers, then there may be several vaccination errors when the disease overcrowded and staff cannot handle the crowd, and sometimes non-trained staff with less experience will vaccinate the clients, and they are not capable enough to manage side effects, so reassure people. So those problems can happen with large scale vaccination programs. And with the vaccination coverage increases, there may be a lot of rumors and anti-vaccine activities, and everything can reduce or people reluctant to come to our vaccination if we don't address these myths, rumors, and the minor side effects occurred with this vaccination. So notification of AEFI also very important. As I told you, community has very low tolerance for AEFIs. That is, they don't like to get even fever after vaccination. But it can happen. But anyway, if there is any adverse events, as even community, all everyone involved or get to know about any AEFI, you should inform it to the into your MOH office. It's very important. If you investigate and if we act promptly, we can overcome these things, and it's very important to notify. So as a general practitioner from a private hospital, MOH office, immunization clinic, or even hospital OPD, sometimes patients come to OPD with Aefi. So you have to notify it to MOH office. There's a good surveillance system about adverse events following immunization. I request from you only to inform to your MOH office regarding the AEFIs. You get to know after that all these procedures will followed by MOHs. So I think this lecture is a concentrated dose of immunization. I think it's a vast subject. We can talk about immunization for days. I think if you are interested or if you want further information, you can visit Bit Unit website. There's a separate section for immunization, all these schedules, immunization handbook, all these published books, guidelines, everything are there. Everything about individual vaccines, even about these private sector vaccines are included in this immunization handbook. Sometimes we also cannot remember everything about the vaccines. So always you can refer that book. Even for frequently asked questions, there's a separate chapter. You can refer this book. Or for further information, you can visit WHO site. So that's all about these basics of vaccinations. If you have any questions, I can answer. Thank you very much.
Thank you very much, madam. We have few questions with us right now. So the first few questions, madam, are based on COVID-19 vaccination. Our audience wants to know, how could Pfizer first dose be a booster?
Yes. Pfizer first dose is not a booster. Pfizer dose is a booster for those who have received the primary vaccination with another type of vaccines. Its primary vaccination means it can be the Sinopharm 2 doses or another Pfizer 2 doses or another AstraZeneca 2 doses. These are the primary vaccinations. Once we received one type of primary vaccination, we developed vaccination in our, we develop immunity in our body. After that, as the third dose, if we get the Pfizer, we will boost up our immunity. Its evidence proves that mix of vaccination give rise to more immune response. So first dose of Pfizer is not a booster dose. If you are vaccinating with Pfizer vaccine, you have to give first Pfizer dose, second Pfizer dose, and the third dose of the Pfizer vaccine is the booster dose. Did I answer your question?
Yes, madam. The next question is, as majority of adults in our country are not willing to get Pfizer, can't we consider vaccinating children as in the developed countries?
Yes, as I told you, vaccination, when we decide on introducing vaccine in mass scale, we have to consider different things. As we all know, it's a new vaccine, only about 1 year old. Usually when it takes 10 years to develop the optimal kind of vaccine. But in a pandemic, we consider about the short-term things, and all these COVID vaccines used in Sri Lanka, those things are have undergone clinical trials in labs and trials in animals and even in humans. So first they were trialed among adults. So we started above 18 vaccination. After that, with the evaluation, we get evidence about the lower age groups. With the evidence, we decided about 12 years. But in developed countries, they have given about 6 years. But still, as I mentioned, we have optimal immunization program. If something happens to a child, that will be the end of our whole program, not only the COVID vaccination. So there's a technical committee, including pediatricians, virologists, physicians, community physicians, everyone is there, and discuss. Even, we started our childhood even about 12 vaccination in later than the developed countries. In our expert study about the risk versus benefit, if benefit overweighs the risk, we decide about the vaccination, because this is given in large scale, so we can experience adverse events as well. And as we know, it's a mild disease in the children, among children. So I think that's the reason. But in future, with the evidence, they may think about introducing in a lower age groups. Still not.
Next question, madam. The audience want to know if females can get the HPV vaccination from the MOH just as the rubella vaccine.
No, it's not in our schedule, because HPV vaccine is recently introduced. So non-immune adults are more, and we cannot afford for that large number. When we decide on an age group, we don't give the women above that age group, but the school children will get. Other problem I mentioned during our my lecture, it should be given before the first sexual exposure. So as a rule, we don't give offer HPV vaccine for above ages. But rubella is something else. It's to prevent congenital rubella syndrome, and majority of the females are vaccinated. So we have very less number to vaccinate.
Next question, also on HPV, madam. If single dose of HPV was taken 1 year back, but still not sexually active, how can we proceed, madam? Can they take one more
I
dose?
think
If
you understand my lecture, answer is there. Age appropriate vaccination is the optimal, but somehow if you miss the vaccine at the first contact with the healthcare workers, they should be offered, even if it as a not delayed. If they have taken first dose 1 year back, now we have to offer, because we cannot go behind the time. Even it's 2 years, now we have to offer the second dose.
Next question is on chickenpox vaccine, madam. The audience want to know if chickenpox vaccine will give lifelong immunity.
Yes, usually recommend single dose. As it's a live vaccine, usually recommend single dose.
The audience also wants to know about the hexavalent vaccination, madam.
Yes, in our
available
EPI
in the
schedule,
private sector.
Yes, in our EPI schedule, we offer pentavalent vaccine, that is DPT and Hpv and Hib. In the private sector, similar vaccine offered as hexavalent with that and 5 antigens. They offer IPV, not the OPV. In our schedule, it's OPV, but in the hexavalent, it's IPV. So no need to give OPV with this hexavalent. But the problem is, when we consider about a vaccine, we go about the epidemiological factors of that community also, that with the oral polio vaccine, this vaccination can be transferred to non-vaccinated, non-immune people also. So still oral polio vaccine is better for our country. So, but IPV with the hexavalent, they develop immunity only for that child. It's skilled one.
Question, madam.
In our
by
system,
any
it's
chance,
live
if
one.
the cold chain is...
Yes.
The next question is, madam, by any chance, if the cold chain is breached, how are we going to manage? Do we need to discard?
Yes, in government sector, if the cold chain breakdown is there, we have to discard whole lot, but we don't know about the private sector. Even with these power cuts and everything, we have that additional backup methods. Almost all the MOHs have generators, so they have to move vaccine to close by hospital, or there are guidelines for those things also. I think usually cold chain breakdowns are not happen, but somehow if there's some problem, we have to discard according to that vaccine while monitors and everything. We go through those things, and if it is proven that it cold chain breakdown, we have to discard. We'll discard. This is about government sector. We are not monitoring the private sector.
Madam, the next question is on the pneumococcal vaccine. They want to know the exact number of booster doses in a pneumococcal vaccine to be given to a child.
Yes, usually pneumococcal vaccines we offer, it's only in private sector, have 3 doses at 2, 4, 6. That's adequate. And I think that this vaccination, these instructions are different from time to time, and you have to follow the manufacturer's guideline with that particular vaccine, but usually it's 3 doses.
The final question, madam, for today. It's again about the HPV vaccine for females. The audience want to know if it's available in the private sector and if there is an age limit to be given in the private sector.
Regarding HPV vaccine, it's available in private sector, but sometimes it's out of stock, but I don't know about that current situation. But if we are vaccinating adults, it needs 3 doses and it has to follow the manufacturer's guideline. And most of the time it's available and it should be given before the sexual exposure. Because it is against HPV vaccine. All these vaccinations are primary prevention before getting the infection. If they have already have this virus, no point getting this vaccine.
Thank you very much, madam. I think that's all the questions for today, and we are getting overwhelming feedback saying thank you very much for all the information that you provided today morning. On behalf of all of us here at Shri, we want to thank you for taking your time and giving us this very informative lecture series for today. And for our participants, thank you very much for coming again today, this morning, to be with us and to join in this lecture. We will post the link for the certificate and the post assessment on the chat box shortly, and you can fill in and obtain your CPD certificate. Madam, thank you again. And we hope to meet all of you again next Sunday with another webinar in our lecture series. Thank you very much.